is Chair, Maternal Fetal Medicine Committee AOFOG, and Dr. Pramila Modi Madam, Dr. Preeti, who is the Chairperson of Safe Motherhood Committee FOGSI, and under whose guidance this workshop is being held. And PPH accounts for a very huge chunk. 38% of the women are dying due to PPH in India. So everyone should know how to manage and tackle postpartum hemorrhage and minimize the deaths due to it. Thank you so much.
Hello. I would like to request Dr. Nibha Mohan to please join us for the proceedings and inaugural session.
Thank you so much. Thank you so much. It's a privilege to convene today's session, today's workshop, so important part of our Labourcon conference. So dignitaries are already on dais, as Al-Qadi has introduced everyone. We'll have lighting of a lamp as a tradition of our this thing. Light, as we say, is a symbol of brightness and prosperity, as sunlight expels darkness of light. Similarly, blessings brings in our life prosperity and happiness. To make this event a blessed one, invoke Goddess Saraswati by lighting the lamp of knowledge and wisdom. For seeking the blessings, I invite the dignitaries from the dais, Dr. Rohana sir, Dr. Alka Pandey madam, Dr. UDP Ratnagiri sir, Dr. Preeti Kumar.
1 minute, Neha. I would like to acknowledge the efforts of Dr. Renu Roy, who had organized the a workshop for healthcare workers in Nalanda Medical College.
Madam, you are welcome to join.
She is principal and she is in charge of the workshop being conducted today. Dr. Neeru Goyal from Indira Gandhi Institute of Medical Sciences, she is the head, and she has also contributed a lot for this workshop. Thank you so much.
So I request Dr. Rohana sir, Dr. UDP Ratnagiri sir, Dr. Alka Pandey madam, Dr. Preeti Kumar, Dr. Pragya, please join, Dr. Meena Saman, the senior most member present here of our PODS society, Madam Dr. Pramila Modi, Dr. Renu Roy, please join, and Dr. Neeru Goyal madam, please come for lighting of the lamp. Yes.
मैम सामने देखिएगा आप
थोड़ा दूर से ले
ठीक है मैम प्लीज मोबाइल
वक्रतुंड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा। वक्रतुंड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा।
मैम सामने देख लीजिएगा
वक्रतुंड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा।
I'll request Dr. Pragya Mishra Chaudhary to join at the dais. Thank you, dignitaries. Now I'll request our guest, Dr. Rohana Hatatua sir, for his words of blessings, as sir has come long way from Sri Lanka. and we need his blessings at the time.
Thank you for giving me this opportunity. Good morning, everybody. I am Rohan Hattuka from Sri Lanka, actually. So, first of all, I must thank Dr. Alka Pandey, who is the organizing chairperson, vice president of OXI, for arranging this congress and also giving support, and also A4G the opportunity to join in this very important conference. So we are very thankful to all the arrangements made on our end. Then also I would like to thank the organizing secretaries, Dr. Vinita Singh, Dr. Pragya Chowdhury, Dr. Meena Sama, for all their hard work and for the communications with our support and the A4G and to so that we are able to participate. And I am also very happy and honored to see the senior obstetricians and gynecologists, Dr. Praveena Modi and Dr. Renu Rohitya in this gathering. Thank you very much for your presence. So, and I would like to thank all the participants who are with us today in this postpartum hemorrhage detection and management workshop. So this I am thankful to Professor Rishikesh Pai, the FOXI president, and Dr. Madhuri Patel, the FOXI secretary general, who have been very cooperative with SAPOC, and they have been conducting so many joint programs throughout India during the past few months. So we are very thankful for the very nice cooperation which we are having with FOXI now with support. And of course, it is Dr. Preeti Kumar, our MFM committee, Maternal Fetal Medicine Committee chairperson. She is a real co-chairperson. Yes. And of course, team of members have the Nikva, Monica, Seema, Mohan and Anupam. So all these have been very active members, and they have been conducting so many workshops for support, not only in India but outside India, in Nepal, Sri Lanka. So this program has gone to other countries also in the South Asian region, because it has been very well organized and very well conducted. And I must say that all the participants enjoy the workshop, because it is not just learning, but they have a very wonderful time. So it is presented in such a way that everyone can learn from it. So that it is so that everyone is towards the end of the workshop, they are more enthusiastic than at the beginning of the workshop. In other workshops, by the time they are waiting till it is over, but here it is not. Everyone is very happy. So as Dr. Alka Pandey said, PVH is one of the most important conditions which we have to address in our regions, because this is one of the major causes of maternal mortality. So this workshop will give us an opportunity for us to learn how to prevent and manage PVH. So without taking any more time, I will thank you very much.
Now request Dr. Preeti Kumar and Dr. Alka Pandey Madam to please felicitate Sir as a token of love and regards. Dr. Pragya, Dr. Meena to join in felicitating Sir.
Science Society. Labourcon 2023 is very obliged and grateful that Dr. Rohana has accepted our kind invitation to do a AOFOG session and SAFOG session. Thank you, sir.
Now, may I request our guest, Dr. UDP Ratna Shri sir, to cover, and we will like to have your blessing, sir. Sir is chair of MFF committee, AOFOG Sri Lanka, and his chairperson IRC RCOG Sri Lanka. And sir also have joined all the way from Sri Lanka to make this workshop so successful. So welcome, sir.
Good morning to you, and thank you very much for giving this opportunity. So first of all, I must thank Dr. Alka Pandey, chairperson of the Labourcon, and Dr. Vinita Singh, all the other dignitaries who are here and inviting us for this workshop. So as the AOFOG chair of the American committee, we are conducting this kind of similar workshops to bring down the maternal morbidity and mortality in the region. So I'm very happy that I have been invited to your country, India. Till last week I was in Nepal. We were conducting another workshop, similar workshop in this regard. So I think maternal mortality and morbidity, as Dr. Rahul Hathuto mentioned, the top priority is to reduce them, the leading cause, the hemorrhage, obstetric hemorrhage. So if you can reduce the obstetric hemorrhage in the region or in the global arena, we can further reduce our maternal mortality rates. So last AICOG I was there in Kolkata, I heard that India has brought down the maternal mortality to 150 per 100,000 from 97 from 150. So it's, I think, congratulate for all of your work. I think the workshops and the training teaching conducted by most of all obstetricians and gynecologists to the obstetricians as the trainings, I think have helped to bring down this maternal mortality. I hope that this workshop will help you to prevent and treat most of these maternal mortality regarding this postpartum hemorrhage. So I congratulate, I think you will take home the messages that the speakers are going to give you in the future in the workshop and bring down your maternal mortality and control the postpartum hemorrhage. Thank you very much.
Now we'll like to felicitate Dr. UDP Ratnagiri, Dr. Preeti Kumar and dignitaries on the dais. Please join in felicitating. Now it's time to felicitate our organizing chairperson of this great conference, Dr. Alka Pandey, Madam. Alka ji, please come forward. Now we'd like to felicitate our organizing secretary, Dr. Pragya Mishra Chaudhary. Dr. Preeti Kumar, please. Now, the sweet and humble our organizing secretary, Dr. Meena. Now we'll have blessings from Dr. And one important felicitation. Chairperson Workshop Committee, Dr. Renu Rohatgi Madam, please come forward.
थोड़ा सा साइड थोड़ा सा यहाँ से लीजिए ना जूम करके ये भी आ जाएगा जूम.
Now we'll have blessings from Dr. Yusuf sir, and he had said his.
I, Professor Yusuf Khan, Secretary General SAFOC, welcome all faculty members and delegates to this hands-on workshop on PPH. I am happy to be part of this prestigious conference, Labourcon, being organized under banner of FOXY at Patna. I wish to congratulate the FOXY President Dr. Pai, Secretary General FOXY Dr. Madhuri Patel, and organizers Dr. Alka Padne, Vice President of FOXY and organizing chairperson of this conference. We also have three dynamic organizing secretary, Dr. Vinta Singh, Dr. Pragya Mishra, and Dr. Meena Samant. We are organizing the PPH workshop for Ops Planning today as FOXY's SAFOC initiative. I would like to express my gratitude to Professor Rohana, President SAFOC, and wish to congratulate Professor Sathya S. and Paul, Chairperson Maternal and Perinatal Committee SAFOC, for conducting this workshop also. I also wish to congratulate Dr. Preeti Kumar, Co-Chair Maternal and Perinatal Committee SAFOC, and Chairperson Safe Motherhood Committee FOXY, and her team for conducting several workshops on PPH in India, Nepal, Sri Lanka, for Ops Gynae as well as.
Thank you. Now we'll have another video message of Chairperson Maternal and Perinatal Committee, SAFOC, Professor Sadia Hassan Pai.
Professor Sadia Hassan Pai, I'm Chairperson of the Maternal and Perinatal Health Committee, SAFOC. I welcome you all to this hands-on workshop on PPH. I'm happy to be part of this prestigious conference remotely, let's say, Labourcon, being organized under the banner of FOXY at Patna. I wish to congratulate the FOXY President, Dr. Pai, Secretary General, Dr. Madhuri Patel, and organizers, Dr. Alka Pandey. The Vice President of FOXY and the organizing chairperson of this conference, Dr. Vinita Singh, Dr. Pragya Mishra, Dr. Meena Samant. This workshop is an initiative of FOXY and SAFOC. I would like to express my gratitude to Professor Rohana, President SAFOC, Dr. Yusuf Latif, Secretary General SAFOC, for providing this opportunity. I also wish to congratulate Dr. Preeti Kumar, who is the co-chairperson, Maternal and Perinatal Committee of SAFOC and chairperson, Safe Motherhood Committee, FOXY, and her team for conducting several workshops on PPH in India, Nepal, and Sri Lanka for healthcare workers and skilled birth attendants, including the obstetricians and gynecologists. I wish and hope that today's workshop is useful for you all and will improve the maternal outcomes in your practices. Thank you very much and good.
Thank you. That's the end of our beautiful short inauguration session. Now we'll start with the scientific session. So I request dignitaries to take their seats. And may I invite chairpersons for this session. UDP sir, you can be there as you are chairing this session. So may I invite Dr. UDP Ratna Sirishar, he is already there. Now I invite Dr. Neeru Goyal madam to come on the dais to chair this session. Neeru madam is a senior consultant and HOD of IGIMS. Welcome madam. And hand over to both the chairpersons to start this session.
Swap मीडिया वाला मिलकर पार्टिसिपेट कर रहा था उसमें फैमिलिया वाला उसको जिद करके बोला हमको कि हम कर रहे हैं अपनी बोली थी फैमिली जिसका मतलब जैसे वो आपका उर्फ एक्सीडेंट उसको तो अभी हम करने आए कि नहीं कर रहे हैं
So good morning everyone. I think rather than taking much of time that we had the inauguration. So I think this session mostly on PPH. So we have two speakers for the first session. Professor Rohan Hattatu from Sri Lanka and Dr. Alkapande from India. So may I invite Dr. Rohan Hattatu. Actually, this workshop is mainly to prevent and control the postpartum hemorrhage, which is a major cause of maternal mortality. So the first speaker, Dr. Rohan Hattatu, if I speak about his short CV, he is the founder chairman of 9 Wells Care Mother and Baby Hospital in Sri Lanka. And he's also the Secretary General of AOFOC. And he's the current president of SAFOC, and also the president of the South Asian Federation of Menopause Societies, SAFOC. And he's also the president of World Gastosis Organization and past chair of the menstrual disorders of FIGO. So without taking a lot of time, so may I invite Professor Rohan Hattatu to speak to you on identification and estimation of blood loss in postpartum hemorrhage. Over to you, Rohan.
Okay, thank you. Thank you, chairpersons, for that very kind introduction and for giving me this opportunity to speak to you. My task is to talk on identification and estimation of blood loss in postpartum hemorrhage. Now, first of all, we all know what is postpartum hemorrhage. It is blood loss more than 500 ml during vaginal delivery or over 1000 ml at cesarean section. But this is not a very practical definition for us in this part of the world, because our patients have a lower blood level, the hemoglobin counts are lower. So if we wait till this, we achieve 500 ml or 1000 ml blood loss, then our patients will be in a very bad state. So it is better for practical purposes have some other definition. So any bleeding after birth of baby of any rate or amount that has the potential to deteriorate the condition of the mother and cause hemodynamic instability and shock. So if there is any amount of bleeding which will cause instability and hemodynamic instability, then we should consider it as postpartum hemorrhage, and we have to take action, because we shouldn't wait till these definitions come into effect. So as we were talking, 830 women die of childbirth every day. That is about every 2 minutes we have a maternal death. And 1/3 died because of hemorrhage during 2003 to 2009. So it is a significant cause. So every 6 to 8 minutes a woman dies of PPH, and annually 15 million have PPH and 75,000 die of PPH. So, but the unfortunate thing is that most of this can be prevented by ultrasonics, medical and consultative or surgical techniques. So that is what is important. So every maternal death we have to be aware, and we have to try and prevent it, because that is what we want. So in India, as we have been saying, hemorrhage is the largest contributor to maternal mortality. So it is responsible to around 40% of maternal deaths, and majority is due to postpartum hemorrhage. Now here you can see, as we were saying, and Dr. Alkapante said that the maternal mortality rate has come down to 97. Now here I have the figures only up to 130, but it had come down from very large numbers, that is 550 to 97. So it is a very, very creditable, and we can all be proud and happy that you have done much work to reduce this. But still, the hemorrhage is the most important one. So this is the thing which we have to address. So here, as you said, I said I have the rate as 112, but it is not very nice to know, because every day this is maternal mortality rate is coming down in India now. So it is coming down at a very rapid rate. So it's very enlarging. So PPH still is the most common, and so there are so many things which have contributed to this reduction in the maternal deaths. It is due to the institution deliveries and the emergency obstetrical care. So this type of workshop, postpartum hemorrhage prevention, is also very helpful, and the Laksha and the Manyata training programs have also been helpful. So we know that postpartum hemorrhage is a life-threatening condition, and if it is left untreated, so within 2 hours even or earlier, a patient can lose the life. So in the prevention and treatment of postpartum hemorrhage, so there are certain things which we can look up to. So that is, there are 3 stages. One is prevention, and then treatment. Of course, the last, if we don't do anything, we go to rescue. So the prevention we can do up to 500 ml of blood loss, then up to 1,000, then we have to somehow treat. But if we exceed 2,000 and about 40% of the blood is lost, then we are in a real situation, that is, we come to the rescue stage. So it would be a very slippery slope to rescue if not prevented or managed well early. So there are determinants of the outcome due to the PPH. This is from the confidential inquiries of UK. The determinants of what will be the outcome of PPH will depend on the patient's blood volume, the pre-delivery hemoglobin level, then the prevention and the early treatment before the onset of coagulopathy and severe shock. If 40% of blood volume is lost, then we come to a very serious situation. So the obstetric hemorrhage, there are certain learning points which we have received from the confidential inquiries in UK. That is important to have a normal hemoglobin. So incidence of PPH is greater with anemia. So anemia magnifies the effect of obstetric hemorrhage. So antenatal anemia should be diagnosed and treated effectively. So parenteral iron therapy should be considered in women who do not respond to oral iron, and I mean sometimes the patients also don't cooperate and don't take the oral iron. So that type of patient also will benefit of parenteral iron. And successive inquiries have shown that the maternal deaths due to PPH was due to too little and too late treatment. So that means too little IV fluids, oxytocin and blood and clotting factors have been used, and also it has been too late to start on prostaglandins resuscitation and the blood replacement, and to decide on surgery and or to get seniors assistance and anesthetists involved. So these are certain things which we have to keep in mind. So too little and too late. So what are the current challenges? So the current challenge is to do anything, we have to first detect it. If we don't detect it, so we can't do anything about it. So what is the fault? So one of the major problems is that is a failure in detection. So early detection and treatment is the solution to prevent maternal deaths from PPH. But as you see this from this chart, 74% of women with PPH over 500 ml did not receive treatment of a uterine duct. So it is a very serious matter. And even with severe PPH, more than 1000 ml, 30% of women did not receive treatment with a uterine duct. So these are some of the facts which we have to keep in mind. So early detection is one of the primary things which we do. For this purpose, what is the most important thing is the estimation of blood loss. So identification of amount of blood loss is one of the key points which we have to keep in mind. So this can be visual estimation or quantification. So we can quantitatively also do. And then later we have to keep in mind that these patients can go into shock. So we have to identify how the early signs and symptoms of that the patient may have a possibility of going into shock. So these are things which we have to monitor. So visual estimation. So what is the earliest identification? So if we see when we are observing a patient that a pad is soaked within 5 minutes, very quickly a pad is getting soaked with blood. So that means there is heavy loss of blood. So these are the pictorial guides. I suppose you would have all seen these things, and this may be in your labor rooms also. So this is very important to know that a soiled sanitary towel contains about 30 ml blood, and a soaked sanitary towel contains completely soaked sanitary 100 ml, and a small soaked sock contains 60 ml. So these, so by counting these things, by collecting these things, then we can get an rough estimate of the blood lost. So this is an incontinence pad, 250, large soaked sock, 45 into 45, 350 ml. So 100 centimeter diameter spill in the floor will be about 1500 ml. And if the PPH is on the bed only, so it may be around 1000 ml. But if it has fallen into the floor also, it may be about 2000 ml. And a full kidney tray will have 500 ml of blood. So these are the things which we have to keep in mind, so that we can get an estimate of the blood loss, which is very important. But as you know, seeing is not believing for blood loss. For others it will be true, but for blood loss it is much more than that. Because not all hemorrhage, the blood loss is visible. And also visual estimation consistently underestimated than the correct blood loss. Because we all don't want to say that there is excessive blood loss. So our visual estimation is always on the lower side. So the quantification of blood loss will be more accurate. So there are a few methods which we can use for quantitative assessment. So blood collected into the grave, or weighing the soaked pads or collected. So with that, and also collecting the blood from the delivery table into a calibrated jug like this, so that we can have a measurement. So these are some of the simple ways of measuring quantitatively. So this is another thing which we have to keep in mind. We always say, no, this is a little bit of trickling, not much of blood loss. So we just continue observing like this, saying that there is only a very mild loss and that we don't have to do anything about it. And if we go on like this until the patient collapses, we will not be doing anything. So continuous slow trickling of blood after delivery should not be ignored, and it is something which we have to take note very seriously. So then these other things which may help that the patient is going into shock, the early signs. So I think Dr. Ratnasiri will be telling about these things later in his lecture. So I will just only superficially just tell you that there is what is called the rule of 30 and the shock index. So the rule of 30 means about 30% of blood loss. Then it's a moderate shock. The pulse rate increases over 30 beats per minute. Respiratory rate is over 30 per minute. And the systolic blood pressure drops by 30 millimeters mercury. Urinary output is less than 30 ml per hour. So hematocrit drop is over 30%. So these are all in 30, so it is very easy to remember. So if these are there, this is called the rule of 30. And then much better than this is the shock index. That is the pulse rate divided by the systolic blood pressure. So if there is a change by 30%, normally this shock index is between 0.5 to 0.7, but in pregnancy the shock index is between 0.7 to 0.9. That means it is below 1. So if the pulse rate is 60 and the systolic blood pressure is 120, then the shock index is 0.5. But when you are charting, we always maintain a chart after delivery. So we have the pulse rate charting and the systolic blood pressure chart. So if these two process each other, so that means the value is over 1. So then we have to be aware of that. So rise by 30% indicates state of shock that needs urgent resuscitation. So these are some of the symptoms and signs that the patient is going into shock. I mean, this you are all familiar with: tachycardia, tachypnea, hypertension, hypothermia, cold heavy extremities, and of course altered consciousness. So these are. So one other thing which I would like to emphasize is the estimated blood loss. When we estimated blood loss should be considered with the body weight, because the blood volume is proportional to the body weight in kilograms. So body weight in kilograms into 100 ml gives the blood volume. So 50 kilogram body weight person will have a 5000 ml of blood. So likewise 55 is 5500. So you can see the blood volume. So if the same amount of blood is lost by a 50 kilogram person, and another, if the same amount is lost by the 70, you can see, 70 the percentage of blood loss in the person will be different. So so that is what we have to keep in mind. So these are some of the signs and symptoms depending on the percentage of blood lost. So these charts are usually available everywhere, so you will be knowing about it. So what are the key messages which we have to take? So that any blood loss from or into the genital tract after delivery of baby of any rate or amount which has the potential to deteriorate the condition of mother and causes hemodynamic instability and shock has to be considered as PVH. and timely identification is crucial. And accurate estimation of blood loss is very essential. And slow trickling of blood should not be missed or ignored. So, thank you very much for your hearing. I just am showing you two stalwarts in that is the Patela Mahamud and Professor Arul Kumar, who we all know, who have been done so much of work. And Professor Arul Kumar has been said, every one of us must take a personal resolution to help those in need. So thank you very much.
Thank you, Dr. Madhu. It was such a nice talk and the important points that you said. Weight of the female is important. Here we have 30 kg females with 3 liters of blood loss. Total 300 volume, 3000, 3 liters total volume, and loss of 1 liter will lead to 30% or more than 30% of blood. And it will change the complete metabolism, and we will be thinking that she has lost a small amount of blood. And the point that small trickles are important, that is very, very important, which we usually ignore. Thank you so much. Now I will like to invite Dr. Alka Pandey. She will be talking on optimizing use of uterotonics in PPH management.
Thank you, Chairpersons.
She was the Associate Professor in the Department of Obs and Gynae at PMCH. She is the National Corresponding Editor of JOGI. She is the Chairperson Practical Obstetric Committee. Presently, she is the Vice President of FOXY.
Thank you so much.
She is the President Patna Obs Gynae Society. She is the Joint Organizing Secretary in the ASUG. And she was the organizing chairperson of Labourcon 2014.
Thank you so much, ma'am. Thank you, Preeti, and thank you, sir, Dr. Lohana, sir, Dr. UDP, sir, for giving me this opportunity to talk on optimizing use of uterotonics in PPH. So, uterotonics are agents which make the uterus contract, and they are used at 3 places. First, to induce labor, then second, to prevent PPH, and third, to treat PPH. So my talk is on optimizing the use of uterotonics in PPH. So I'll talk the prevention and therapeutic part. So this, sir has already said, Rohana sir, he has defined PPH as loss of 500 ml of blood within 24 hours of delivery. One thing I would like to say that already he has spoken about everything. I want to add one thing only, कि massive PPH is blood loss more than 2 liters of blood and requiring 4 units or more of blood transfusion. The incidence is 35% of all maternal deaths worldwide. The incidence of PPH is 2 to 4% after vaginal delivery and 6% after cesarean section. Now, causes of maternal mortality. You can see here that our dynamic Prime Minister is so much after saving precious lives, and under his regime, the maternal mortality has come to 97. Now, out of all the causes of maternal death, PPH is the major killer. So, there is a report from Kerala that in spite of near total hospital deliveries, very good antenatal coverage, improvement in blood transfusion facilities, and many developments in technology to arrest the bleeding, deaths due to PPH have remained a persistent concern. And they were highest in 20 to 29 age group And at 46%, atonic PPH is the most common type of obstetric hemorrhage. Moreover, a third of PPH deaths were recorded in cesarean section births, highlighting the importance of practicing safe cesarean section techniques and post-operative monitoring. So risk factors we all know: age more than 40 years, high BMI, Asian African ethnicity, multiple pregnancy, placenta previa, anemia. Anemia has got much focus because it has been found that women dying due to PPH also had anemia from before. Then preeclampsia, hypertension, previous PPH, instrumental deliveries, macrosomia, retained placenta, previous cesarean sections, placenta accreta or percreta, and prolonged third stage are important risk factors for PPH. So now, what are the causes which lead to PPH? So we all know trauma, tissue, thrombin and tone. Tone is the most important, and approximately 70% of the PPH is due to atonic uterus. 20% due to trauma, 10% due to tissue, and 1% due to thrombin. So atonic PPH causes about 70 to 75% deaths in PPH. So we have to concentrate to stop atonic hemorrhage. So re-emphasizing about that every pregnancy is at risk for PPH. Occurrence of PPH is often unpredictable. However, you might be prepared, but you cannot predict who is going to have PPH. And this is one thing which all obstetricians are very much scared of. Possibility of obstetric hemorrhage will always coexist with pregnancy, whether anticipated or not. PPH risk factors identify less than 40% of cases of maternal hemorrhage. Therefore, risk factors alone are not adequate predictors of PPH, and active prevention is indicated for every delivery. So as Sir has already said, PPH can kill even a healthy woman within 2 hours if unattended. So prevention of atonic PPH has 2 parts. First part, care before prevention, training and infrastructure. And second is active management of third stage of labor plus uterotonic agents for sustained contraction. PPH prevention involves the practice of active management of third stage of labor for all patients, irrespective of mode of delivery and place of delivery. We have to identify those at high risk for postpartum hemorrhage, such as patients with prolonged labor, preeclampsia, previous PPH, and multiple pregnancy. But this is losing credibility now, as 60% women have no risk factors. So we have to be prepared to prevent PPH. For the pregnant women, it is advised that birth preparedness and complication readiness for pregnant women, family members and service providers, they should have adequate antenatal checkups and investigations. And for the health workers, they should be adequate in number, skilled and with updated knowledge, which Preeti is going on propagating, and emergency response team with team division. Then facility readiness is with traffic signal approach for triage, green, yellow and red, adequate infrastructure, appropriate equipment, instruments and consumables, PPH kit, crash kit trolley, appropriate medications such as all uterotonics, tranexamic acid, special requirement for uterine balloon tamponade, and NASD, suction cannula and transvaginal uterine artery clamps. Blood and blood products should be readily available, and PPH checklist and debriefing forms. Then protocols and procedures, partography is mandatory, CTG in high-risk situations, active management of third stage of labor in all cases, and use of safe birthing checklist and surgical safety checklist. Now we have to anticipate, prevent and perform risk assessment optimal prenatal care, correction of anemia and nutritional management, and management of medical conditions by multidisciplinary approach for optimization of the condition. So active management is mainly prophylactic uterotonic drugs, clamping of the cord, controlled traction of the umbilical cord only when skilled health care workers are available, and uterine massage also should not be sustained, and only in the presence of skilled health workers. So for PPH prevention, in third stage of labor, after birth of the last baby, whether there is skilled provider or not, if not, in the villages, misoprostol 600 microgram orally can be given, and if the health provider is present, skilled health provider, then oxytocin 10 international unit IV or IM in all births if unavailable, or if the quality cannot be guaranteed, one of the following can be used based on clinical eligibility and availability. Misoprostol 400 micrograms or 600 micrograms orally, then carbetocin 100 micrograms intramuscular or IV, ergometrin or methyl ergometrin can be given. Oxytocin and ergometrin fixed dose combination also can be used. If there is birth asphyxia, we have to do early cord clamping, and if there is no asphyxia, late cord clamping in 1 to 3 minutes, but initiate essential newborn care. And about controlled contraction, if there is skilled provider, then controlled contraction should be given, and if there is no skilled provider, no controlled contraction should be given, because there will be risk of inversion of the uterus. So uterotonics may be oxytocin, carbetocin, ergometrin, symptometrin, misoprostol. The half-life of oxytocin is 3 to 5 minutes, but it binds to the oxytocin receptors, but it may cause tachycardia, hypotension, myocardial ischemia, and free water retention. Carbetocin has a half-life of 40 minutes. It also binds to oxytocin receptors, but duration of the uterine activity is longer. It has significantly fewer adverse events, headache, nausea, and abdominal pain. Ergometrin, the half-life is 2 to 4 hours. It significantly increases motor activity and produces myometrial contractions, but it is not to be given in hypertension because it causes hypertension, it may cause myocardial infarction, it may cause stroke also. Then symptometrin, same as ergometrin, it causes headache, dizziness, hypertension, chest pain, and prostaglandin, that is misoprostol. It is involved in cervical ripening, and it may cause fever, chills, nausea, vomiting, and diarrhea. It also prevents PPH. So, what are the concerns with available uterotonics? They require special storage conditions, 2 to 8 degrees centigrade, questionable efficacy after drug degradation, and associated side effects. So, oxytocin is given in 10 unit intramuscular, 5 unit in IV diluted to 5 ml over 1 to 2 minutes slowly, or 20 units in 500 ml NS or ringer lactate infusion at the rate of 150 or 125 ml per hour. The onset of action is within 2 to 3 minutes, side effects are minimal, and you have to be very careful in cases of cardiovascular failure and heart diseases. Misoprostol is 600 microgram orally, and I've already said it causes shivering and slight rise. There is no contraindication. Ergometrin, the onset begins at 2 to 7 minutes, lasts for 2 to 4 hours, and it may increase the risk of retained placenta if you give it beforehand, not before the delivery of the placenta. Then it may cause nausea, vomiting, headache, and hypertension, and it should be avoided in hypertension, heart disease, and RH negative women and also severely anemic women. Then carboprost 250 microgram, onset is 1 to 2 minutes, causes vomiting, diarrhea and bronchospasm, and it should be avoided in cases of bronchial asthma. Now concerns with available uterotonics. Oxytocin requires special storage conditions 2 to 8 degrees centigrade, multiple dosing, and overdose or prolonged use can cause water intoxication, and prolonged use itself can lead to uterine atony. Argometrin requires special storage 2 to 8 degrees centigrade. It increases nausea, vomiting and diarrhea, nausea and vomiting, and it needs to be avoided in HDP, including chronic hypertension. Misoprostol is less effective in preventing PPH. It has more side effects associated with higher risk of severe PPH and increased use of additional uterotonics. Then carboprost, it requires special storage conditions 2 to 8 degrees centigrade, associated with side effects like vomiting, diarrhea and bronchospasm, and needs to be avoided in patients with asthma or significant renal, hepatic or cardiac disease. Now syntocinon requires refrigeration and must always be administered by injection. The dose is 20 international unit in 500 ml of crystalloid solution. The intravenous route is used with the dosage rate adjusted according to the response. Now carbetocin, is it a solution to all the concerns of oxytocin? The drawbacks of oxytocin are antidiuretic effect, multiple dosing regimen, short acting, repeat doses required, stability and quality issues, and all of these can be addressed by carbetocin. Now symptometrin requires refrigeration. It can be administered intramuscularly or intravenously at a dose of 1 ampoule, 500 microgram of ergometrin and 5 international unit of syntocinon. It is contraindicated in hypertension and cardiac diseases. Then syntocinon versus oxytocin, it can be given by intramuscular route, and the preferred storage to oxytocin is refrigeration, but it may be stored at temperature of up to 30 degrees centigrade for up to 3 months without significant loss of potency. The misoprostol does not require refrigeration. It is easy to administer, it is inexpensive and widely available for the treatment of PPH, and a single dose of misoprostol 800 microgram administered sublingually following delivery can be given if IV oxytocin is not available. So a single dose of misoprostol 800 microgram administered sublingually in vaginal delivery if IV oxytocin is already given for treatment of PPH. What I wanted to say is repeat doses of misoprostol for PPH treatment are not recommended. The side effects already have been said many times. Then prostaglandin F2 alpha, it requires refrigeration. It can be administered intramuscularly. Maximum number of doses 15 minutes apart. That is 2 milligram maximum. It is contraindicated in asthma and cardiac disease. Prostaglandin F2 alpha is not effective after giving 2 doses. So if it is not working, then we should not give. Tranexamic acid 1 to 2 gram hourly will reduce fibrinolysis and will stabilize the clot in the uterine vessels. It is given via the intravenous route, best used when the bleeding continues despite oxytocin and when prostaglandin has become necessary. Carbetocin is a synthetic oxytocin analog that binds to the same oxytocin receptors in the myometrium with an affinity similar to that of oxytocin, and it is 4-fold longer uterotonic activity. This means there is no necessity for a continuous infusion. Carbetocin 100 microgram as an IV bolus over 1 minute instead of continuous oxytocin infusion can be given, and there is robust evidence in elective cesarean section for the prevention of PPH, and it has been shown to decrease the need for additional therapeutic uterotonics, and it is thus economic as well. Then for women delivering vaginally, carbetocin decreases the need for uterine massage, need for other uterotonic drugs, and need for blood transfusion. So Champion trial was carried out worldwide, randomized multicentric double-blind active controlled non-inferiority trial, 23 sites in 10 countries, and the primary outcomes. There were about 29,645 women, and it was compared with oxytocin, and it was found not to be inferior in any way with oxytocin. So the recommending body WHO has said that for PPH prophylaxis, oxytocin is the gold standard, but carbetocin is the next which we can give. And Canada also says carbetocin 100 microgram IV bolus. Then FIGO, carbetocin, one of the recommendations for PPH management. And in Germany also carbetocin. Then France also carbetocin on proving non-inferiority to oxytocin, achieved by Champion trial. So this already has been said by Rohana sir. So what we have to do is initial resuscitation with airway breathing circulation disability, uterine massage, bimanual compression if required, indwelling catheterization, uterotonic medication, 2 14 to 16 gauge cannulas in both the hands, take blood for full blood count, coagulation screen, renal and liver function tests, then cross-packed red cells. Volume replacement must be done quickly, and this involves restoration of both blood volume and oxygen carrying capacity. As rapidly as possible, 2 liters of warm saline, normal saline should be given, or RL. Then blood transfusion as soon as blood is available. Then control contraction if the placenta has not yet been delivered, and remove any clots or remaining tissue, and continuously assess the blood loss. You have to monitor the vital signs, pulse, respiration, blood pressure every 15 minutes, and modified early obstetric warning score will aid monitoring. Then we have to palpate the uterus for finding out whether the bleeding is due to atony. And in case of uterine atony, the primary response is to do uterine or bimanual uterine compression, aortic compression, and administer uterotonics. Tranexamic acid injection, 1 gram intravenous to be given immediately within 3 hours of PPH, and repeat another 1 gram IV after 30 minutes if PPH persists. So here the emphasis is that you have to give tranexamic acid as quickly as possible, because if you give it late, probably it causes harm. If the uterus has contracted, then you have to see for the genital tract trauma, and if detected, appropriate intervention should be taken. Evaluation for blood coagulation abnormalities, and if the patient is still bleeding and goes in refractory PPH, then we can use uterine balloon tamponade, uterine suction, NASG, and if the woman is still bleeding, she can be taken for surgical compression sutures, uterine artery ligation, uterine artery embolization, and hysterectomy. So we are all using this condom balloon tamponade. Then NASG probably is not being used much in Bihar, and then B-ridge compression suture can be done for atonic uterus. And this suction cannula is very effective. We have tried in many cases, and it is very effective in controlling PPH, atonic PPH. So diet to give life is a reality. And these pictures, they are a constant reminder that we have to work for PPH and to minimize. She is Smita Patil, a very talented actress, and she lost her life due to secondary PPH. Mumtaz Mahal, we all know in whose memory this Taj Mahal is being erected. And so FIGO also says that save mothers, stop PPH, and thank you very much for giving me this opportunity.
Thank you so much. Thank you both the speakers, Dr. Rohana sir, Dr. Alka Pandey madam, for your exhaustive, wonderful talks. I think delegates must have good take-home message. And thank you, chairpersons, Dr. Ratna Siri sir and Neeru madam, for sparing your valuable time. That's the end of our first scientific session. And we have another very interesting and important second scientific session.
There are a few questions that have comments that
Okay.
Thank you, Rohana sir, and thank you, Alka ji, for that wonderful lecture. Just few things I want to clarify here, because most of the PGs are sitting here, and I was just going through the pre-training survey. A lot of gaps are there. So just one point I need to highlight is carboprost is not used for the active management of third stage of labor. That's the take-home message right now, that the carboprost is a uterotonic that should not be used for the active management of third stage of labor. It's for the management of PPH. That's the first point. The second question I would like to ask all the experts sitting here. There was a question from FIGO, because we did one project in UP on FIGO PPH project. The question that was raised was that the first drug of choice is oxytocin, always the oxytocin for the as a uterotonic for management of PPH. How long will you wait to add on the second uterotonic? That's a very important question, because you should not overload the patient with uterotonics if the patient is having PPH. So just want to have certain clarities on this point, because this is a very important question. Suppose if you have given oxytocin, how long will you wait to add on to the second uterotonic?
I think, see, you have given uterotonic for what? Prevention or management? So, if you have given this oxytocin, you have given it in this IV fluid. So, I think we must wait for 15 to 20 minutes.
Sir, your comments were relating to Sir Professor Rohana.
Yes, very important question. I think, if it is the atonic uterus, now we have given all the bolus, and usually we continue with an infusion. So when you continue with an infusion, when you overload fluids, there is a chance of other problems, hemodilution as well as the antidiuretic effect. So waiting and giving the second dose, you have to identify the uterine hardness and the continuity of the bleeding, rather than timed intervals. It is the clinical assessment then and there with the experienced person. Now, inexperienced may cause worse. So get the always experienced person's advice. So it may not be the oxytocin next time, it may be the ergometry or the second line drugs. But giving all the drugs together is also not used, and it may do harm. So with the timely assessment, the uterine hardness, the bleeding, sometimes the bleeding may not be due to atony, though you give repeated doses, but we have to keep it contracted until you are sorting out the problem. Thank you.
Not on this thing, but because the PGs are sitting here and they have to understand one or two things, that they have to understand why the females die within 2 hours if PPH is not managed. That is because of the blood supply to the uterus, which is about 600 to 700 ml per minute. And if it is not controlled, 2 घंटा तो बहुत ज़्यादा है, वो तो उसके पहले मर जाएगी. Within minutes, her liters and liters of blood will be lost. That is one. And why is PPH very, very important? And in fact, prevention of PPH is very important in cases of hypertension, preeclampsia, because there is hemoconcentration, there is no dilution of blood, the blood vessels are already constricted, therefore the compensatory body mechanism of vasoconstriction is missing, and even 200-300 ml of blood loss can lead to hypotension. Therefore, you have to be very, very careful in managing the patients of hypertension. And the tone of uterus, it fails to come back if patient is hypoxic. Once the hemoglobin level goes down, the patient becomes hypoxic, and at that time oxygenation will be very important, and any kind of uterotonic will not work. Whatever you may be giving, at that time either uterine packing with whatever you have, if you don't have balloon tamponade, or if you have balloon tamponade, do that, but still be very, very careful. Oxygenation is very important. Thank you.
Thank you. Again, just want to highlight regarding the previous question, everyone should be aware about the onset of action of every uterotonic. Because, and how long it is sustained. Like methergine is a drug which is now not used as a, if it is not there, oxytocin is definitely your first drug of choice. But the effect is much more sustained if you give methergine. So it's not, if it is not a contraindication, like the patient is not a heart disease, or she's not a case of hypertension or something like that, and suppose if the patient is having a PPH after a prolonged labor, then the uterus gets relaxed quite often. So if you want to add the second drug after oxytocin, then methergine could be a better choice because the effect is much more. That is why Alka ji showed you how the onset of action and how prolonged the action is. So just put that chart in your labor room or somewhere where you can just go on reading and reading so that you can have an idea which uterotonic is best, like oxytocin, which would be the next one. You have list of uterotonics, so that's very, very important. So thank you so much, Ritu ji and Dr. UDP sir, for your comments.
Thank you so much. We had such a
Thanks to the organizers for giving us this chance.
And thank you, madam, for sparing your valuable time. So starting with the next session, may I invite the chairpersons of this session.